Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of hypocalcemia that was presented to our ER. Shall we begin?
Yes.
A 45-year-old female was rolled into ER with the complaints of generalized numbness, tingling and all over the palms, feet and over the face. She was taken into the ER. So initial 10-second assessment, patient was conscious and oriented, but she could talk relevantly in full sentences. So we went to the primary survey. Primary survey, patient's airway was patent. There was no signs of any airway compromise. There was no pooling of secretions, hoarseness of voice, stridor or any other signs of airway compromise. Coming to breathing, patient was having adequate chest excursions bilaterally. Patient was slightly tachypneic and patient air entry was bilaterally equal and there was no added breath sounds. Coming to circulation part, patient pulse rate was 80 per minute. It was regular in rhythm and BP was 130 by 70 millimeters of mercury. While checking the BP itself, her hand went into the spasm. So while checking the blood pressure, her hand had a spasm presentation also. So it is mostly pointing, along with her presenting symptom, mostly pointing to a hypocalcemia.
What is the sign known as?
Trucius sign, sir.
Trucius.
So, a circulation part, we had secured one IV cannula, sir. Large bore IV cannula was secured because...
Why do you want large bore in this case?
Sir, calcium, we will have to administer calcium, IV calcium because it is a symptomatic hypocalcemia. Okay. So, calcium can cause thrombophlebitis and it is like an irritant. So calcium gluconate we can give through peripheral cannula, but preferably a large bore cannula. Okay. And if it was a calcium chloride we are administering, we can't administer it through a peripheral cannula. We will have to put a central line and all. So in acute setting, we can give a calcium gluconate, preferably through a large bore cannula in view of the effect of the drug causing thrombophlebitis and all those.
So, what is the difference between calcium chloride and calcium gluconate?
Calcium chloride will provide 3 times the same dose of calcium chloride will provide 3 times the elemental calcium than calcium gluconate. Okay. That is 10% 10 ml calcium gluconate contains 92 mg of elemental calcium, but calcium chloride the same will be containing around 272 mg of elemental calcium. So in an acute severe hypocalcemia, the preferable agent is calcium chloride, but we usually do not administer it in view of the severe corrosion and all those effects, and it will warrant a central line for administering. So in ED, mostly we will be going for a calcium gluconate. The circulation part was this, and coming to disability, patient sensorium was GCS 15 on 15, pupils were equally reacting bilaterally, and her GRBS was 94 milligram per deciliter. And coming to exposure part, patient had the spasm appearance of her upper limb, the fingers, and bilaterally she had the spasm. She also complained of severe numbness and paresthesia bilaterally, and also over the face area she had complained of the paresthesia and numbness.
All over the face area, or what is the classical presentation of hypocalcemia? It is a
perioral. Basically, perioral paresthesia and numbness will be the initial presentation. Okay. So, in this patient, we strongly suspected hypocalcemia because of the clinical signs which was evident even from the primary assessment. So, we took a blood gas analysis. Basically, blood gas analysis will give us an idea of the acid-base status, because hypocalcemia will be mostly associated with alkalosis. Other thing is our blood gas analysis will give us the ionized calcium levels also. So because of that we went for a blood gas. So it was showing a metabolic alkalosis with a pH of 7.506, a bicarb of 30 and a PCO2 of 39 and a ionized calcium of 0.45. So normal is like around 1.2. So this is very much reduced. And also we had connected her to continuous cardiac monitoring, and also a 12 lead ECG was taken. ECG was showing a heart rate of around 70 with a QT corrected QT of 430. So it was within the normal range. So, but in view of this symptomatic episode, we had administered her with a IV calcium gluconate. So we had given her 10 ml, 10% calcium gluconate. One dose was given, and it was like repeated till she was symptomatically better. So around 2 doses of IV was given, and followed by a IV infusion was started. By the time we went with the sample history and the secondary examination, the patient's history wise, patient has no history of any drug allergies. Past medical history, patient is a non-case of multifocal papillary carcinoma thyroid, status post thyroidectomy around 2 months back, and was on radiation radio ablation also. And following that, she had episode of hypercalcemia around 2 weeks back, and following that she had to undergo hemodialysis 3 sessions for the hypercalcemia, the refractory hypercalcemia. So following this event, she was discharged home, and that time she was not having any calcium supplementation. But now like she had presented with a hypocalcemia episode. So the hypercalcemia was corrected 2 weeks back, and now she had present with hypocalcemia like episodes. The complaint was mainly numbness and paresthesia and frequent muscle cramps for the last 2-3 days. While getting like prolonged sitting and all, she had frequent episodes of muscle cramps. So this was the basic like history and event leading to the current presentation. Then the system-wise examination, like the general examination, we had checked for the specific signs of hypocalcemia. The Shostak sign was checked, which is like tapping of the facial nerve in front of the ear. So there will be the twitching of angle of mouth and the facial nerve region. There will be
grimacing of
face will be there. Then Tournier sign was positive, and she in presentation itself she had the carpopedal spasm. Then other system-wise examination, respiratory system, like all the systems were within normal limit. The air entry was bilaterally equal, no signs of any aspiration or anything. Then the patient per-abdomen was soft and non-tender. The CVS also was normal, and there was no sense like CNS examination, no obvious motor weakness or paralysis, nothing was there. So, so we are like what we had is a symptomatic hypocalcemia patient post like because of a post surgery and radiation like papillary carcinoma thyroid post surgery radiation patient having hypocalcemia. So like what we have to do is the acute management, which is the IV boluses of calcium, and also we have to start on the calcium like infusion also, IV calcium infusion also to maintain the calcium, because the calcium like after bolus there is a chance of it coming down. So we'll require a...
So for which patients you will start IV calcium infusion?
If the patient like is symptomatic and like there is a symptom or a ECG change or anything, we'll have to start on a IV calcium infusion.
No. You gave for symptomatic carpopedal spasm and Shostak sign, you started IV bolus calcium, right? IV calcium over 15 minutes you are given. Patient symptomatically improved with the second dose of calcium. Now, after this, what factor will decide whether to start the patient on IV calcium infusion or not?
This patient, the hypocalcemia is because of the hypoparathyroidism, because like thyroid related that parathyroid has been removed or something like.
But she had hypercalcemia 2 weeks back, right? Whether that hypercalcemia was evaluated?
That hypercalcemia was a drug-induced hypercalcemia. She was like on calcium supplementation and all at that time, and then she developed a like drug-induced hypercalcemia.
Okay. So her parathyroid levels were sent earlier?
This episode it was not sent.
No. Initially.
Earlier it was a low parathyroid.
Okay. So how will hypocalcemia means what will be the parathyroid levels be in hypocalcemia?
Hypocalcemia. Hypocalcemia, there can be like a low parathyroid hypocalcemia. That is, if there is a post parathyroid removal or
Patient's calcium and parathyroid hormone level, how it is correlated?
basically hypocalcemia, there can be both hypo or hyper, both can happen. If it is because of a low parathyroid, can be because of iatrogenic causes or any genetic causes or autoimmune disorders and all.
Okay, anything that suppresses parathyroid levels. Yeah.
Or if it is if the hypocalcemia is because of other causes like a vitamin D deficiency or like sepsis, pancreatitis, certain drugs and all, the parathyroid level will be like high.
So normally, physiologically, any low calcium levels, any calcium level goes down, parathyroid level will be elevated. So if you get a parathyroid level which is normal or low in a hypocalcemic patient, that means patient's parathyroid is affected. Patient's parathyroid level should not be normal at all. It should be elevated in hypocalcemia. If it is not elevated, there is a problem with parathyroid gland. So you have to think about parathyroid, hypoparathyroidism and do the evaluation. But then you need to think about a continuous calcium infusion. Okay. So what other factors do calcium levels depend upon?
Then one is vitamin D levels, because vitamin D helps in intestinal absorption of calcium.
Okay.
So if there is a severe vitamin D deficiency, there can be hypocalcemia.
Okay.
Then other thing is magnesium levels. If there is a magnesium deficiency, there will be a parathyroid level will go down, and the
parathyroid level will go down, or
because the effect of parathyroid, something like a parathyroid resistance will be there.
Resistance to parathyroid hormone sensitivity to calcium. The calcium will not be released to parathyroid hormone. So parathyroid hormones levels will be elevated, but calcium will be low and magnesium will also be low. So what does that mean clinically? What is importance there?
So we have to correct magnesium and then correct calcium.
We need to send serum magnesium levels. So if serum magnesium levels are low, on top of calcium correction, we need to give magnesium correction also.
Then other thing is if some conditions like renal failure, there can be hypocalcemia. Then
why in renal failure there is hypocalcemia?
That is because kidney, the vitamin D, like from calcidiol to calcitriol, the conversion is happening in kidney. So because of that, the vitamin D won't be converted into that active form. And
because of that, vitamin D deficiency causing hypocalcemia. Fine.
Then the other thing is in malignancies, there can be like sometimes tumor lysis syndrome causing hypocalcemia.
Yes.
That is basically the phosphate and calcium will bind, and hence the serum calcium level will be low. Because of increased phosphate, calcium will come down. Then other thing is in pancreatitis, there can be hypocalcemia. That is because the calcium combining with the free fat forming soap, saponification. So because of that, calcium level will be low. Then it can be because of drugs. So drugs.
What are the most common drugs that can cause?
The drugs given for this hypocalcemia, basically citrate drugs, phosphates, bisphosphonates. Then loop diuretics can cause some amount of.
But loop diuretics will not, the normal dosage of loop diuretics will not cause hypocalcemia as such, right?
Then
blood transfusion.
Blood transfusion.
Blood transfusion.
Citrate.
Does one blood transfusion causes hypocalcemia?
No. When multiple, like around 4 to 6 bags of blood and all are transfused in a short span, because of citrate citrate effect, there can be hypocalcemia.
Okay.
Then other drugs are like hypocalcemia drugs.
Commonly used one.
Steroids.
Steroids. That's why we say chronic, long-standing steroid use causes osteoporosis, right? Yes.
Then
fine. Let's move on. If in ER, if a patient is presenting with these classical findings, you initially told that I will ask for a blood gas analysis. In blood gas analysis, what is the important factor that you are looking into?
Basically, if the patient is having a transient hypocalcemia because of a respiratory alkalosis, then that symptom can be, we can control it by like a rebreathing, provide a rebreathing thing and the IV calcium at that time. It doesn't warrant a infusion because it is the transient episode because of the alkalosis.
Okay.
So,
what is the connection with alkalosis?
When there is alkalosis, the positive binding sites of the albumin will be like left free because H plus will be moved, and that negative sites will be free. So calcium being a positive thing will bind to the albumin.
More affinity of calcium towards albumin. So less ionized calcium in the blood, causing patient to have acute worsening.
So the total calcium will be normal, but ionized calcium will be low.
So do you want a blood gas analysis to diagnose this thing?
No, symptomatically if patient is tachypneic, like hyperventilating.
Yes, tachypnea or hyperventilation? Hyperventilation. That is completely different to tachypnea. Tachypneic patients usually will not have hypocalcemia. Patients hyperventilating will cause it. What is the difference between tachypnea and hyperventilation?
Rate and depth both will be like more.
Yes, there will be CO2 washout. Forced washout of CO2 happening in hyperventilation, while tachypnea is basically caused by air hunger to promote normal ventilation, isn't it? Fine. So, first and foremost, let's recap. When a patient comes to ER with a carpopedal spasm or perioral numbness, we are suspecting hypocalcemia. Hypocalcemia diagnosis is pretty straightforward, isn't it? Patient will have classical features because it is not something that patient can adjust to it. So, if you have hypocalcemia, how will you proceed?
Hypocalcemia, the emergencies related with this, like there is a chance of like if the patient is having going into tetany, like coming to airway breathing like that, if the patient is going into tetany, there can be a chance of laryngeal spasm. So if we are going into severe hypocalcemia, tetany and all, we'll have to be beware of that. That is an emergency.
So basically, we then also look into whether it's a reversible cause or irreversible cause, right? The first thing is whether the patient is having a hyperventilation episode or the patient is having a clear pathological hypocalcemia. That's the first thing. Our 10-second assessment, we can clearly understand whether the patient is hyperventilating or not. If hyperventilating, then our management is more supportive rather than aggressive management. Of course, even in hyperventilating patient, you have to give
IV bolus of calcium
if the patient is having
spasms,
because spasm is very painful and takes longer time to resolve. So we will give, but even then our infusions and further investigations can be minimized, isn't it? Now, if you think the patient is not hyperventilating, then we are dealing with a pathology, isn't it? So as you initially told, you have to check for airway, if airway is patency, and look for laryngeal tetany. Laryngeal tetany can cause vocal cord spasm, and vocal cords can be, go into tetany and close of airway. Then you may have to surgical airway has to be placed. What will be the earliest sign? Any vocal cord?
Hoarseness will be.
Yes, hoarseness and progressing to stridor. So, hoarseness and stridor should always be looked into. Moving on from airway, you have breathing. Usually, breathing will not be affected as such other than the airway. Circulation, you are looking for basically any tachycardia, that's the main thing, and arrhythmias. Arrhythmias, you need to take a ECG, which comes in primary assessment. Then but you need to have one large bore IV access available, because you can't predict when the patient will go into spasm. Even if the patient doesn't have spasm right now, patient can develop spasm anytime. If the patient has perioral numbness itself, that is a symptomatology. You need to put IV access. So you need IV access there. Once IV access is put, then you can continue your assessment and then take investigations to confirm any cardiac involvement of hypocalcemia. As you told, ECG you will take. And even then, if you are deciding to give calcium, you need to give it over 15 minutes under ECG monitoring. Then at that point, your till this much we have already covered. At that point, your decision is whether to investigate further or not. What are the things that you will send?
Like first thing is other electrolytes like magnesium, potassium should be like checked for.
Good.
Importantly, this magnesium and potassium.
Not either potassium or phosphorus.
Magnesium, potassium, phosphorus. These three
Magnesium,
things.
potassium, phosphorus, right.
Then other.
Does potassium has direct correlation to calcium?
It is not like there will be like coexisting hypokalemia, hypocalcemia in hypomagnesemia.
Like that, but mainly magnesium and phosphorus has a direct relation to calcium. So magnesium and phosphorus should be sent. But since magnesium can affect potassium levels, we are sending a potassium level too. Fine.
The next thing is like a renal function test. Creatinine should be checked.
Yes, of course. Renal failure has to be ruled out.
Then
albumin should be.
That is the first and foremost thing that we should do, because we need to identify whether there is a hypoalbuminemia causing hypocalcemia.
Pseudo-hypocalcemia or a hypocalcemia.
So serum albumin level is the first and foremost test we should do. Because if there is albumin deficiency, then we are looking not into a real hypocalcemia.
Pseudo-hypocalcemia.
So all other investigations and everything can be withheld. Okay, so serum albumin levels is the important factor. Then
vitamin D level should be checked.
True, but vitamin D level being not a commonly done investigation and doesn't have any emergency repercussions and a very costly investigation, serum vitamin D levels, serum parathyroid hormone levels should be reserved for patients who are planning to get admitted. Isn't it? Because if you think it is a irreversible hypocalcemia, you are going to admit the patient for continuous calcium infusion. Those patients can do these investigations before starting the infusion protocol. But sending from ER is not really going to help you out, because these tests takes their own time to come the results, and by that time you may not have the patient with you, right? Anything else that you need to mention in hypocalcemia?
No, like investigation from ER side is these things, but as I told, like if an infusion is we are planning to start infusion, we have to send the vitamin D and parathyroid levels before that.
Okay.
Then comes to like the management. So management is if like the patient is symptomatic, then we have to go for IV. If the patient is asymptomatic and if the patient is having like a chronically having hypocalcemia, patient was not at all symptomatic, then we can go for oral treatment. Like IV in IV treatment, as already told, it is IV boluses, which is mostly calcium gluconate. 10% we will be getting 10 ml. So that like up to around 30 ml we have to give. Can be given as bolus, and the infusion protocol is like we can take 5 ampules of calcium gluconate in 1 pint of NS or D5 water. So it will be like the 5 ampules will be coming to around 450 to 500 mg of elemental calcium in 500 ml, and initially we can start it at a rate of 20 to 30 ml per hour. And we have to target the serum calcium level around like 9, above 9. So when the calcium level is increasing above 9, we can reduce the rate of infusion by half the dose, and the calcium level should be corrected calcium level should be checked every 4th hourly to maintain the calcium levels. And along with this infusion, we will add on oral calcium supplementation also for a long term effect. And once the calcium levels are stabilized, we can slowly taper the calcium infusion and stop, and the calcium supplementation, oral supplementation will take over. So that oral supplementation, we will get like tablets of calcium carbonates, that is 500 milligram tablets we will get, and mostly available is along with a combination of vitamin D. So the common thing we prescribe is a brand of Shelcal 500, which will be calcium carbonate 500 with vitamin D 250 international unit. So it can be given like as a 1 gram TID, like that is 3 to 4 gram can be divided into TID doses and given that oral dose. And other thing is the vitamin D metabolite calcitriol, so that has to be given. So that is
where indicated.
In the vitamin D deficiency.
Okay, so that is post workup, which is not under our part, so that's fine with us. So this is the hypocalcemia.
Then the other treatment all are depending on the causes. If it is like vitamin D deficiency, we have to supplement that. If it is due to a primary hypoparathyroidism, recombinant parathyroid hormone, all will be there, so that we can supplement. Then this is the basic management.
What is the relationship between serum calcium levels and albumin?
Serum calcium, the corrected calcium is equal to serum calcium plus 4 minus the albumin into 0.8. Yes. So that is the formula for the corrected calcium.
So for every 1 gram reduction in albumin, there will be
0.8 reduction in calcium.
Calcium levels will be there. Okay. Anything else to be added on? No. You covered, right? Okay. You can sign.